Welcome, everyone. Thank you for joining us today. I hope you're all staying safe, active, and healthy during these uncertain times. My name is Carrie Grady-Vincent, and I'm the Senior Manager of Scientific and Clinical Programs here at Osteoporosis Canada. I have been a registered dietitian for over 30 years, working in many diverse roles. Today, I will be the moderator for our webinar on diabetes and bone disease. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Osteoporosis Canada is the only national organization serving people who have or are at risk for osteoporosis. The organization works to educate, empower, and support individuals and communities in the risk reduction and treatment of osteoporosis. At Osteoporosis Canada, we educate Canadians about bone health, including healthcare professionals and their clients. We are excited about today's presentation. We will be providing general information about diabetes and bone health. It is not our intention to provide individual advice and suggest for more information to talk to your family doctor or osteoporosis specialist. If you have questions during the webinar, please remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many of them as we can in the time allowed. So without further delay, let's get started. It's my privilege to introduce our speaker. Dr. Claudia Gagnon is an associate professor in the Department of Medicine at the University of Laval and a clinician researcher scholar of the Fonds de Recherche en Santé du Québec. She devotes 50% of her time as a researcher at CHU de Quebec Research Center and at Quebec Heart and Lung Institute Research Center in Quebec City. She also practices as an adult endocrinologist at CHU de Quebec. After completing a residency training in adult endocrinology at the University of Sherbrooke in 2006, she undertook a 3-year fellowship in Melbourne, Australia. Her research today focuses on the impact of obesity, diabetes, and their treatments, and in particular bariatric surgery on bone health. She has received funding from Diabetes Canada, Diabetes Quebec, and the Canadian Institutes of Health Research, and has published over 50 articles in peer-reviewed journals. She has been the recipient of many awards throughout her career, and she is also a wonderful member of our Scientific Advisory Council and is currently our vice chair. And so without further ado, it's my privilege to turn things over to Dr. Gagnon. Claudia?
Thanks so much, Carrie, for the introduction. I'll just share my screen now. Okay, so I'm really truly thrilled and happy to be presenting to you all this afternoon on bone disease and diabetes, especially at this to this specific audience, because I guess that some of you may be either people living with type 1 or type 2 diabetes, or friends or family members of people living with diabetes, or even healthcare providers who take care of people with diabetes. So I hope that no matter who you are, my presentation will meet your expectations today. So before starting my presentation, I'd like to mention that I received honoraria for presentations and for advisory board meetings and research grants from pharmaceutical companies who manufacture insulin or anti-diabetic or anti-osteoporosis drugs. So at the end of my presentation, I hope that you will have learned at least something on these objectives. So my first objective is to contrast bone disease, in people with type 1 and type 2 diabetes. So to highlight the differences and the similarities, to identify the risk factors for fracture in people with type 1 and type 2 diabetes, and also better understand why people with diabetes have increased bone fragility. And finally, my third objective will be to discuss the prevention and treatment of bone disease in people with diabetes. So before starting my presentation, I like to make sure that everyone knows the difference between type 1 and type 2 diabetes. So in both diseases, the blood sugar is higher than normal. But the cause of high blood sugar is different between both types of diabetes. So type 1 diabetes is more rare than type 2 diabetes. So it's about 10% of within people, 10% of people with diabetes have type 1 diabetes. So it usually occurs either in childhood, adolescents, or in young adults, although we sometimes see people that present at an older age. So the cause of high blood sugar in type 1 diabetes is a destruction of the insulin-producing cells in the pancreas by the immune system. So our first-line defense system against infection, but that now attacks the insulin-producing cells. So that results in low insulin levels. Try to imagine insulin as the key that allows glucose to go from the blood within the cells. And we know that glucose is an important source of energy for all cells. So type 1 diabetes is usually treated with insulin, what we call basal bolus type of regimen. So people usually inject long-acting insulin once a day and rapid-acting insulin with meals. So type 1 diabetes is an autoimmune disease that may be associated with other autoimmune diseases such as rheumatoid arthritis, celiac disease, and early menopause, which is defined as menopause happening before the age of 45. If we look at type 2 diabetes now, so it's been traditionally diagnosed in older people, although that's less true now because we see more and more children and younger adults diagnosed with type 2 diabetes. And why is that so? It's because of the increase in the prevalence of obesity. So type 2 diabetes is really strongly associated with excess weight. That will then create what we call insulin resistance, so an resistance to the action of insulin. So you have enough of that key, that's insulin, but the key is not working properly. So it's once again difficult for glucose to go from the blood within the cell. And so what will the body do? It will try to compensate at first by increasing the production of insulin by the pancreas. So if you measure insulin levels in the blood of people with type 2 diabetes, it will be higher than normal. It will work for time, but at some point, the pancreas becomes, if you wish, tired, and the production of insulin by the pancreas will not be enough to overcome insulin resistance. So the blood sugar will then increase from a state of pre-diabetes to type 2 diabetes. So type 2 diabetes is usually treated with pills, but at some point, many people will end up needing also insulin. And we put a lot of emphasis on the maintenance of healthy weight in people with type 2 diabetes. I wanted also to clarify what's osteoporosis for those of you who may not be as familiar with it. So some people will sometimes mix what's osteoporosis and osteoarthritis. So while both diseases are really prevalent in the older population, they are very different. So osteoarthritis is a degenerative joint disease, and most of the time it's painful. So the people know they have osteoarthritis at some point. But osteoporosis is a state of bone fragility. So you cannot feel that your bone is fragile. So it's a silent disease until your first fracture. So in osteoporosis, bone is weaker because of older age, and we call that primary osteoporosis, or because of certain diseases or medications, and we call that secondary osteoporosis. So diabetes is a secondary cause of osteoporosis. So how do I know if I have osteoporosis? So unfortunately, oftentimes fragility fracture is the first manifestation of osteoporosis. So it's a fracture that can happen at any bone site except the toes, feet, fingers, and fractures of the head. And if you didn't have a fracture, osteoporosis can be diagnosed before the first fracture by using what we call bone mineral density, or a BMD test, which is a type of X-ray, and it enables calculating the mineral content in your bone. So if it is lower than normal, we can diagnose osteoporosis. So let's start now with bone disease in the context of diabetes. So I'd like to start with stating that it's truly an under-recognized complication of diabetes. Most people will know that diabetes is associated with nerve damage, kidney damage, eye damage, but most people won't know that it's also associated with bone disease. So a colleague of mine, Suzanne Morin at McGill University, and her student, Catherine Drummond, conducted a survey across Canada that included people with type 1 and type 2 diabetes. And they've asked them whether they believed that diabetes increased their risk of fracture. And 8 out of 10 people said no. They also asked them if they were informed by their physician that diabetes increased their risk of fracture. And once again, over 9 people out of 10 said that they weren't informed by their physician. So these data shows us that there's still a lot of work to do to increase the awareness of bone disease in the context of diabetes for people living with diabetes, but also for the healthcare providers. So I'll start by presenting 2 clinical cases. The first one is about a patient living with type 1 diabetes, and the second case about a patient living with type 2 diabetes. So while I present those 2 cases, I'd like you to try to think about the risk factors for fracture that you're able to identify in these cases, and we'll come back to those along the presentation. Sorry. So the first case is a 58-year-old postmenopausal woman with a normal weight. So she had her menopause at an age of 44, so it's early menopause by definition. So she had a long-standing diabetes, She was diagnosed at age 2, so she's been living with the disease for 56 years. She has several complications of diabetes, so nerve, kidney, and eye damage. Her blood glucose is not optimal. So for those of you who know diabetes, we can measure what we call HbA1c, or glycated hemoglobin, which reflects blood glucose over the last 3 months. And usually, so it depends on the patient, but we will generally aim for an HbA1c below 7% without frequent episodes of hypoglycemia or low blood sugar. So her HbA1c has been around 8 to 8.5% over the last few years. She takes several meds typical for patients with diabetes, so cholesterol, for hypertension. She takes insulin 4 times a day, and also vitamin D and calcium supplements. She never had a fracture, but she did fall in the last year. So her doctor ordered a BMD test, which was adequate, and it turned out to be low in the osteoporosis range. The second case is again a 58-year-old postmenopausal woman with obesity. So she was diagnosed with type 2 diabetes at age 40, so almost again 2 decades of having diabetes. Again, all the several complications of diabetes. Her blood glucose is not optimal as well, with an HbA1c of about 7.5 to 8%. She takes meds for cholesterol, hypertension, and diabetes pills, vitamin D and calcium supplements. She never had a fracture, but did fall in the last year. And BMD test was ordered, and it was normal. Oops. So what about fracture risk in people with diabetes? So in both types of diabetes, the risk of having a fracture is higher than people without diabetes, but there are differences between the 2 types of diabetes. So if we start with people with type 1 diabetes, their risk of having any type of fracture is 4 times higher in women and twice higher in men with type 1 diabetes compared with people of the same age and sex, but without diabetes. And this increased risk of fracture is seen across the lifespan, starting in childhood. And it's truly most striking at the hip, with an increased risk of fracture ranging between 3 and 8% and 8 times higher at any age. In people with type 2 diabetes, the risk is also higher than people without diabetes, but it's lower than in people with type 1 diabetes. So you'll see there that the risk of different types of fractures varies between 1.2 and 1.4 times higher. So why should we care about fractures in people in general, but especially in people with diabetes? Because it's been shown that people with diabetes experience delayed fracture healing. They are at a higher risk of complications after the surgery for fracture repair. They're at higher risk of death and reduced independence in daily living and quality of life. So it's important to try to prevent the first fracture and subsequent fractures in this population. So now let's move on to what are the risk factors for fracture in both types of diabetes, and why do people with diabetes have bone fragility? So fracture risk depends on factors that are linked to bone itself, but also non-bone factors. So let's start with the bone-related factors. So bone strength depends on two main things, so bone mass and bone quality. We can assess in the clinic bone mass by using a BMD test, like I've discussed before. But bone quality is not that easy to measure in clinical practice. It's mainly research tools. So bone quality is an umbrella term that comprises three main components. So the rate of bone turnover, bone microarchitecture. I'll show you a picture in the next few slides to illustrate what's bone microarchitecture and bone material properties within the bone, so the quality of the collagen and other components of bone. So here's my image of bone. So it's an image of the wrist, it's different parts of the wrist. So you can see here the cortex in white, and you can see here like an honeycomb type of structure, which is the trabecular bone. So here's an image of someone who doesn't have diabetes and never had a fracture. So you can see that bone is a strong structure. So here you have an image of someone without diabetes, but who did have a fracture. So you can see that the honeycomb structure is a bit weakened here, more space within the trabecular bone. You can perhaps guess that the cortex is a bit thinner as well. But look at the bones of the people with type 2 diabetes in the next two here. So this one is someone with type 2 diabetes who didn't have a fracture. So again, the quality of the trabecular bone is less, but the cortex is even thinner and you can see some holes there. And someone with type 2 diabetes and a fracture, so the bone is very affected. In particular, cortical bone, you can see like the Swiss cheese-like holes there within the cortex. And they've shown that the longer the duration of diabetes, the more likely you have to have these holes there. And some other studies have shown that if you have complications of diabetes, so vascular disease, you can have these holes as well. So if we go back to the yellow circles that I had before, so bone mass in both, I'll go back. So fracture risk is much higher in people with type 1 than in people with type 2 diabetes, as I've said before. So bone strength is lower in type 1 than in type 2 diabetes. One main difference between the types of diabetes is that bone mass is generally lower in people with type 1 diabetes compared to those without diabetes, but it's often not enough to explain bone fragility. In people with type 2 diabetes, bone mass is generally normal or even higher than normal. And we think that it's explained by the fact that the excess weight increases the mechanical strain on the bone, and perhaps also due to certain hormones that may increase bone mass in people with type 2 diabetes. But both types of diabetes are characterized by decreased bone quality. So all the properties of bone that I've named before are altered. So now let's move on to the second part, so the non-bone related factors that increase fracture risk. So I've divided them into two types. So some factors are not specific to people with diabetes. So older age, menopause, a family history of fracture or osteoporosis, a history of falls, certain medications. But some factors are specific to people with diabetes. So I've listed them here in this slide. So you can see that the presence of diabetes complications is associated with an increased risk of fracture in both types of diabetes. Poor glycemic control, so generally defined as an HbA1c greater than 7 or 8%, is also a risk factor in both types of diabetes. Longer diabetes duration, generally we think of greater than 10 years. It's again a risk factor in both types of diabetes. Having severe hypoglycemic episodes, which means altered consciousness that may trigger a fall, is a risk factor in both types of diabetes. And the two last factors are specific to people with type 1 diabetes. So the diagnosis of diabetes before the age of 20 and the presence of celiac disease. So bone disease in diabetes is complex and still incompletely understood. I've tried to summarize in this slide what we know so far about bone disease in diabetes. So if your blood glucose level has been higher than normal for most of the days and for long duration of time, so it has an impact directly on your bone. So it decreases the rate of bone turnover, which will ultimately increase bone fragility. Also, high blood glucose will create something called the AGEs in your bone, and AGEs are compounds that form with glucose. So what we know, it's mostly collagen in the bone that will link with sugar. Collagen is important in the bone because it makes your bone more flexible. So if you have sugar linked to your collagen, it will make your collagen stiffer, and the accumulation of a great quantity of these compounds will fragilize bone as well. So longer duration of diabetes will increase the bone AGEs. Longer duration of diabetes is also associated with the development of diabetes complications, so nerve, kidney, and eye damage that may lead to bone microarchitecture defects and ultimately to a fracture. Diabetes complications, so vision impairment or nerve damage, may increase the risk of falling. Low blood sugar, so especially severe hypoglycemia, can lead to falls, and most fracture results from a fall. So now we'll start the last part of my presentation on how to prevent and treat bone disease in people with diabetes. So it's a relatively new knowledge that we have on bone fragility in the context of diabetes, but experts in the field and scientists have gathered and they've published clinical guidelines on the diagnosis and management, specifically on bone fragility in diabetes. So what do they say? So the recommendations are the same as for people without diabetes. So it's important to maintain a healthy lifestyle, to maintain adequate calcium intake through a diet, or if it's not possible, add calcium supplements. The recommendations are to reach a calcium intake of 1,000 milligrams a day for those age 18 to 50 years and 1,200 milligrams a day for those age 50 years and over. To take vitamin D supplements because the diet is not very rich in vitamin D. I would say that in Canada, between fall and the winter, it's good to take around 800 to 1,000 units of vitamin D a day. And throughout the year, if you do not get enough sunlight exposure during the spring and the summer. Adequate protein intake as well. And stop smoking and reduce alcohol intake. Because we know how bad they are on the lungs and on the liver, but what people do not know often, it's also bad for the bone cells. It's important also to perform exercises. So people living with diabetes often hear about the importance of aerobic type of exercise. So it's good for cardiovascular health, of course, but for bone, you need to have some type of strength exercise and balance exercise to help reduce the risk of falling. So for examples of balance exercises are Tai Chi, dancing, walking on your toes. So you have resources on the website of Osteoporosis Canada, for example, to guide people with diabetes to make sure they do the right exercises to improve their bone, but also muscle health. So it's also important to incorporate fall prevention strategies. So these are general recommendations for people without diabetes, but for those with diabetes, it's important also to reduce the number and severity of hypoglycemia or low blood sugar, and to optimize diabetes control as much as possible. On a yearly basis, it's great to review the medication list to make sure that it's still right, that the hypertension pills maintain the blood pressure within the normal range, but not too low to create a dizziness and increase the risk of falling. And if required, anti-osteoporosis drugs will be started. So I've prepared a checklist here for your doctor if you're living with diabetes. So it's important to mention if you had a fragility fracture or a fall, because that's not generally the types of questions that your endocrinologist or your GP will ask you at a regular visit for your diabetes. You will also mention if you lost more than 6 centimeters in height since the age of 25, because that may be a sign of a vertebral fracture. And most vertebral fractures are asymptomatic, so you do not have any symptoms of that. BMD test should be prescribed in people who are age 50 years and over with diabetes, or earlier if you have other conditions affecting the bone, such as rheumatoid arthritis and celiac disease, or if you had a fragility fracture. If you do not take a vitamin D supplement, it would be good to have one prescribed, and to check if you have enough calcium in your diet. And if it's not the case, add a calcium supplement. And do physical activity that specifically designed to maintain your bone and muscle health. But for people with diabetes, it's important to discuss the risk of hypoglycemia that may be induced by exercise, to make sure you have tips to help prevent those. And work on reducing hypoglycemic events, reducing the risk of falls, and reaching, if possible, individualized target HbA1c. So there are, some people may wonder what's the impact of anti-diabetic medications on bone. So I've divided them into 3 groups. So some that are safe for bone, the medications that are a yellow light, so with some risk associated with it, and the red light. So You must know that most medications for diabetes are considered safe for bone. So metformin, for example, which is widely prescribed, a class of drug called the DPP4 inhibitors or GLP-1 receptor agonist, which is an injection daily or once a week, they're all safe for bone. Some meds are associated with some risk of fracture, and these are medications that may result in an increased risk of hypoglycemia. So some pills called the sulfonylureas, insulin, of course, and canagliflozin has been associated in some studies with an increased risk of falls and fractures, especially in the first few weeks after starting the medication. And an increased risk of fractures has been associated with some pills for diabetes called rosiglitazone and pioglitazone. These pills are not widely used anymore, having said that. So, and what about the effectiveness of the anti-osteoporosis medications to prevent fractures in people with diabetes? So unfortunately, there's no high quality study that has been specifically done in people with diabetes, but stay tuned because some studies are ongoing. So we should have the results of those in the upcoming years. Having said that, the available data suggests that the effectiveness is similar in people with diabetes than in those without diabetes. But we have so far very limited data in people with type 1 diabetes. So the general consensus is if you need to have anti-osteoporosis drug, it should be started because we think that it's as effective in this population as in people without diabetes. So I'll finish my presentation by going back to the clinical cases and suggestions of what we should do with these patients. So the clinical case 1 was this 58-year-old postmenopausal woman with early menopause. So I've put in red the risk factors for fracture that I asked you to guess at the start of my presentation. So she had long-standing diabetes. She had a lot of diabetes complications, not optimally controlled diabetes with frequent hypoglycemic episodes, meds for hypertension, insulin, and she had a fall in the last year. And her BMD test was low. So for her, based on fracture risk calculation, so there are tools to calculate her risk of fracture and see if we should start anti-osteoporosis drugs. And she has an indication for starting these drugs. We will discuss fall prevention strategies with this patient. Work on improving the glycemic control while reducing, if possible, the risk of hypoglycemia. And will prescribe weight-bearing and balanced exercises. So by referring the patient to the Osteoporosis Canada website, for example, there are also community centers that may offer some of those programs specifically for people with osteoporosis, or if they have the money, they can see a physio or a kinesiologist. So the second case, so again, this patient was postmenopausal, which is a risk factor. She had long-standing type 2 diabetes, diabetes complications, diabetes that wasn't optimally controlled, meds for hypertension, and she was taking one type of pill, diabetes pill, that can increase her risk of hypoglycemia, which is called glycoside. And she did fall in the last year. As mentioned in my presentation, her BMD was normal, which is the case for most patients with type 2 diabetes. So for her, there's no indication for anti-osteoporosis drugs, But on a yearly basis, it would be good to ask for fracture, falls, reevaluate the medications, the lifestyle, and order a follow-up BMD based on the guidelines. We'll discuss fall prevention strategies because she fell in the last year. We will work on improving glycemic control while reducing hypoglycemia, and again, weight bearing and balance exercises. So to conclude my presentation, here are some take-home messages. So first of all, fracture risk is higher in patients with both types of diabetes, but it's higher in people with type 1 diabetes, and it starts at an earlier age in those with type 1 diabetes. So bone fragility is explained mostly by a problem of bone quality in both types of diabetes. And people with type 1 diabetes are at greater risk because their bone mass is generally lower than normal, whereas in people with type 2 diabetes is generally normal or higher than normal. So among people with diabetes, those who are particularly at risk for future fracture are those who have poorly controlled diabetes with hypoglycemia, complications of diabetes, and longer duration of the disease. So it's important for people living with diabetes and for healthcare providers to ask about fractures and falls at each medical visit, and if possible to address risk factors that can be modified, and if required, indicated an anti-osteoporosis drug will be started. But as I've mentioned, we need more studies in this population. So with that, just wanted to mention that if you want to know more about this topic, there are podcasts on diabetes and osteoporosis on the website of Osteoporosis Canada. So I hope you enjoyed the presentation, and I'm ready to answer your questions.
Wow, that was great, Claudia. Thank you so much. So much information to think about. And we've got some time for some questions, and we'll do our best to answer as many questions in the allotted time as we possibly can. And there's quite a few good questions coming in. So let's get started. And our first question is, after a diagnosis of osteoporosis in someone with diabetes, can bone density be increased?
Yeah, so that's a great question. Yes, so there are several ways by which BMD can be increased. So via maintenance of adequate vitamin D, calcium, and protein intake, by doing resistance type of exercises, by using anti-osteoporosis drugs as well. And there's also some data that show that some of the anti-diabetic medications may increase bone mineral density. Having said that, we have to remember that even BMD stabilization is a great goal in the osteoporosis field, and that's also true for people with diabetes, because as you get older, bone mass tends to decrease, so you lose bone mass. So if you're able to maintain and stabilize bone mass, that's also good.
Okay. How do you prevent hypoglycemic episodes, and how do they increase the risk of fracture?
Good question. So hypoglycemia is important to address, but it's also difficult to address in clinical practice. It's something that people with type 1 diabetes always have to live with. it's quite difficult to reach target blood glucose without experiencing some hypoglycemia. But the ultimate goal would be to reduce the number and the severity of these episodes. In people with type 2 diabetes, only those who have medications that increase hypoglycemia, so insulin and some types of pills like glycoside can increase the risk of hypoglycemia. But we now have a lot of anti-diabetic medications that do not cause hypoglycemia, which is a good thing. So to reduce the risk of hypoglycemia, so these episodes tend to happen in people with type 1 diabetes. For example, if the carb content is not adequate during physical activity also. So it's always good to review with the team. So by meeting a nutritionist to review carb content, for example, or with an exercise specialist or with your doctor that can give you tips on how to reduce your risk of hypoglycemia during exercise. Your insulin may need to be adjusted as well. So it's how we kind of work to reduce hypoglycemia. And now trying to understand, so the next part of the question was to know how hypoglycemia increase fracture risk. So we think it's mainly through increasing the risk of fall. But there may also be a direct effect of several episodes of hypoglycemia directly on bone, but it's still unclear.
Okay. How can I recognize if my bone health is improving?
So unfortunately, that's difficult to recognize how your bone is improving. It's not like osteoarthritis, as I mentioned. You'll know that you're better because you have less pain. For osteoporosis, it's a silent disease. So there's no real way to know it's improving clinically, but you can have an idea that it's improving if you have a bone density test. Having said that, being stable or improving BMD is good. But it's not the whole story, because we can't know if bone quality has improved by controlling diabetes or reducing diabetes complications. So it has its limitations, unfortunately.
Okay. Here's another one. Is walking enough, or do I need a resistance exercise as well?
Yeah, another good question. Walking is great, in general for cardiovascular health, that's great. But you have to be careful, especially during the winter, to avoid falling on the ice. So often we have fractures happening that way. But truly, to improve bone health, you do need to add resistance training in addition to walking. That would be even better.
Okay. I'm cognizant of the time, so I'm watching it closely. So we'll have time for just a couple more questions. Can insulin resistance be reversed?
Yeah, I like this question. So that's mainly for people with type 2 diabetes, but we see also nowadays more and more people with type 1 diabetes who also have some degree of insulin resistance because they are overweight or obese. So that may apply to both groups of people with diabetes. So my short answer is yes. It can be improved, certainly. by reducing the weight, though that's one thing, through lifestyle modifications, so diet and exercise. And we also have medications, anti-diabetic pills that will act directly on improving insulin resistance, such as metformin, for example. And we also have some medications for diabetes that now are able to reduce weight as well. So these medications may also improve greatly insulin resistance.
Okay, I'm going to switch gears here. I don't like to drink milk. What are some other ways to increase my calcium and protein?
Okay, so that's a question that we get quite often for people, for example, who are vegan or are lactose intolerant, or who just don't like to drink milk or any other dairy. So there are many other sources of calcium and protein besides dairy. You can go on the website of Osteoporosis Canada. Once again, there's a great calcium calculator that you can use. You have the portions and the amount of calcium that each type of food contains. So you have, for example, now a great choice of plant-based beverages such as calcium fortified soy milk, almond beverages. So they're great sources of calcium. You also have nuts, seeds. So, and for protein, you also have the meat as well.
Okay, so this will be last question. The person would like to know, what should I discuss with my doctor if I have diabetes about my bone health?
So great. So I hope that after hearing my presentation, you'll be able to discuss with your doctor at your next visit bone health. You remember this slide I presented on the checklist for my doctor? So we'll have this checklist available for you all as a PDF document that you can download and print to bring with you at your next visit. So you should discuss fracture, falls, see if you have enough vitamin D, calcium, see if you meet the criteria to have a BMD test done, and try to work on improving glycemic control, hypoglycemia, and all that we've discussed in the presentation.
All right. Wow, that's a lot of information today. Thank you so much, Dr. Gagnon. It's been an informative presentation on diabetes and bone health.
That's a pleasure.
I want to remind our listeners that if they want more information on osteoporosis, to please visit our website at osteoporosis.ca. There you'll find many different tools. You can see them on the slide here. We have a calculate your calcium tool. We have podcasts, quizzes, and a repository of past webinars. And one of them does feature Dr. Gagnon, so that's wonderful. And thanks to all of you for joining us today, and wishing you all a wonderful day. Thanks again.